Thank you very much, Dr. Bass. Thank you, Professor Bess, for the invitation. So today, yes, I would like to discuss these difficulties in TET staging classification of the era of 9th TNM. I have no conflict of interest. So as you know, after resection, PT evaluation is crucial for the management of patients with TET. For the 8th edition, ISLC and RYTHMIC proposed a classification based on more than 10,000 patients with survival more than 8,000. The Thymic domain of Staging and Prognostic Factor Committee of the IASLC for the 9th edition proposed a classification based on more than 11,000 patients and survival in more than 9,000 patients. As you can see, both for the 8th and the 9th classification, a tumor that is either encapsulated or invading mediastinal fat or invading the mediastinal pleura is considered as PT1. However, for the 8th, PT1B is linked to invasion of mediastinal pleura, whereas mediastinal pleura invasion is only a descriptor in the 9th classification, and PT1A is a tumor that is 5 centimeters or less in its greatest dimension compared to PT1B. Concerning Concerning PT2, PT2 for the 8th classification is restricted to tumor invading the pericardium, whereas for the 9th TNM, it gathers both pericardium invasion as well as lung and phrenic nerve invasion. For the 8th classification, lung and phrenic nerve invasion are considered as PT3. An important step that had been achieved by RYTHMIC starting from 2011 was to define invasion of mediastinal pleura, pericardium, and lung histologically. For mediastinal pleura invasion, it was mainly a penetration through the elastin layer of mediastinal pleura. For pericardium invasion, it was mainly invasion of the fibrous layer of the pericardium. And for lung invasion, it was a direct penetration into the outer elastin layer of the visceral pleura or into the lung parenchyma. To maintain consistency in data collection, it was suggested to use this criteria for PT, although not clearly defined. In our French RYTHMIC network, we evaluated the PT stage because for each case included, the initial pathologist contributing is asked to send all the H&E of the resection, and for each case is reviewed by at least 2 pathologists, and since 2015, independently by the reviewers using digitalized slides. And when there is discordance, we discuss with all members and we use the consensus diagnosis. We reported in 2021 that for the first 467 patients, there was discordances between the local initial pathologist and the central review in around 15% of cases. And as you can see, after central review, there were more stage 3, meaning for either mediastinal pleura, pericardium, or more lung invasion compared to the initial pathologist. We are currently performing an update on the 34 cases, and we submit for the RYTHMIC meeting an abstract. However, within the RYTHMIC network, we observe that even between the experts, there were kind of discordances when there is an independent review by the 2 experts of the PT evaluation. And as you can see in yellow here, there are discrepancy between the 2 experts, either considering is there mediastinal pleura invasion, is there pericardial invasion or not, is there lung invasion or not. Therefore, we decided to conduct a study within the RYTHMIC group, and it was to build a study with the RYTHMIC because it was crucial for us to be able to reproducibly assess the PT on slides and to share and validate within the RYTHMIC the criteria we used in France. And therefore, we selected digitalized slides during the RYTHMIC procedure concerning challenging cases of PT1A, PT1B, PT2, PT3 with an international group from the RYTHMIC. We first evaluated a series of 5 cases, then have WebEx discussion to try to reach a consensus, and then a validation series of 10 more cases. What are the results? In fact, for the initial tester series, as you can see, between the experts of the RYTHMIC, the concordancy was slight, and in fact, no case were classified with the same PT, and the typical case is on the right side, in which there is either PT1A, PT1B, and or either PT3 lung invasion. It was linked mainly to a thymic tumor that are sticking to the lung, and as you can see, sometimes can be very tricky to classify. For the validation series, we used for each case immunostain to try to enhance reproducibility and elastic fiber staining. As you can see, the kappa concordancy was better, it was moderate, but still there are discrepancies between the 6 experts, and no case were classified still with the same PT, but we increased the concordancy. Therefore, we found out some histological landmark from the consensus analysis, and I would like to share with you some of the landmarks. Concerning what we observe mainly is that, as you see in this scheme, there is destruction of the capsula and invasion through the mediastinal pleura. But in fact, what happens often, especially in thymoma, is that the tumor is growing with this thick capsule and sticking here to the mediastinal pleura. Here, you can see very well that, in fact, you have this tumor with this strong capsule, which is sticking to the lung and sticking also to the mediastinal pleura. Mediastinal pleura invasion on slide is often difficult to diagnose. In rare cases like here, it can be easy because you recognize here the mesothelial cells and that you have the tumor cells invading the mediastinal pleura. But what we observe, for example, is that the elastic layer of the mediastinal pleura is not always present. Here you have this mediastinal pleura here. You can see very well in dark the elastin layer on this part of the mediastinal pleura, but as you can see here, there is not at all elastin layer, and we think this cannot be, therefore, a reliable tool to diagnose invasion. As you can see also, mesothelial cells can be very scarce on mediastinal pleura. As you can see of the whole mediastinal pleura, there are only mesothelial cells here. So to be sure here that you are dealing with mediastinal pleura is difficult. And as you can see, this is confirmed by calretinine staining that shows the staining only here, whereas there is not at all any staining here. And even here, as you can see on this slide, there is a tumor growing with the capsula. It is sticking to this fibrous band of tissue, and there was not really a consensus among the experts to be sure that here we are dealing with mediastinal pleura. Concerning pericardium invasion, as you can see, pericardium invasion is defined by the invasion of the fibrosa. Here you have the pericardium with fibrosa, the mesothelial cells, and you have here the outer pericardial layer, which is not itself in the pericardium. We use elastin stain because it's helpful sometimes to see in the fibrosa presence of elastin fibers associated with a wavy collagen, and it can help sometimes to differentiate capsula from pericardium. And as you can see here in this case that has been difficult within the RYTHMIC pathologist, this case, in fact, is there any pericardium invasion or not? And in fact, after discussion and consensus, here we have large vessels, and therefore here we are still in the outer pericardial layer, and therefore there is no pericardium invasion. Concerning lung invasion, here this tumor is sticking to the visceral pleura. We cannot see any mesothelial cells. The thymoma is sticking to mesothelial, but you can see very easily in the visceral pleura the outer elastin layer because the technique is very good, and here the inner elastin layer. And here this is the alveoli. You can see outer elastin layer is very respected, therefore there is no lung invasion here, although sticking to the lung. Here also, this tumor here is sticking to the lung. You can see the alveoli, a little thin band of fibrosa, of mediastinal, of visceral pleura. And here you can see that calretinine helped a lot because you can see that here your mesothelial cells of the visceral pleura, therefore there is this thymoma and no lung invasion. So to conclude, in fact, reproducibility of PT staging on TET on slide is an issue at both a national and international level. In fact, what happens is that thymoma grow often with a capsula that they stick to mediastinal pleura, to the lung, to pericardium, sometimes can be difficult to really diagnose invasion. There are difficulties on mediastinal pleura recognition and invasion. This support additional studies, and this fit well also with the 9th TNM that support to consider mediastinal pleura only as a descriptor. We found out that, in fact, immunohistochemistry and elastin help to improve reproducibility, and that slide images also may help to improve consensus interpretation. And it was also important to follow the TNM rule that when we are not sure, is to apply the lower stage when there is no definite evidence of the higher stage diagnosis. And I would like finally to underline again the importance of strong surgeon-pathologist collaboration for a reproducible PT evaluation, especially with the areas of concern. And with that, I would like to thank patients participating to the study, and also pathologists from the RYTHMIC network that sent all the slides of their patients, and my colleagues from the RYTHMIC networks, and also for the HYTHMIC that participate to this RYTHMIC study. Thank you.